औज़ुबिल्लाहिमिनश्शैतानिर्रजीम बिस्मिल्लाहिर्रहमानिर्रहीम। अच्छा देखिए, जो पोस्ट मेनोपॉज़ल वुमेन होती है ना, उनमें अगर हमें ओवेरियन सिस्ट मिले, so we are basically our focus should be to go towards conservative management as much as possible. You're not going to go for surgery right away because they are going to have comorbidities. They cannot withstand the stress of a major surgery. Okay, so unlike young women, in which if they're symptomatic, if they want, for example, if they want a myomectomy for fibroid, you can't refuse them if they are symptomatic. But for postmenopausal, you have to be very careful before going for a major surgery. तो इसीलिए जो गाइडलाइन है वो ये कहती है कि आपने कंजर्वेटिव मैनेजमेंट यूज़ करनी है जहाँ तक हो सके. ये ना हो कि CA-125 उसका आसमानों को पहुँचा और आप कहें कंजर्वेटिव. ऐसा नहीं है. Where possible and where suitable. And when you want to go for a surgery, then you should prefer a laparoscopically done technique over a laparotomy. Just for the same reasons, because they cannot withstand the stress that much. And whenever you are suspecting a malignancy, you are going to refer to a gynecological oncologist whenever possible. So these three things are the blueprint of this guideline, and you should keep these in mind. Okay. अच्छा, सो बेसिकली बहुत कॉमन होती हैं पोस्ट मेनोपॉज़ल में इंसिडेंट्स ना. 5 to 17% मेंशन हुआ. इट्स क्वाइट वेरिएबल. सो हाउ आर दे गोइंग टू प्रेजेंट. अब एक खातून हैं, क्या वो आपके पास आपको बताएंगी कि मैं पोस्ट मेनोपॉज़ल हूँ, आई एम 55 एंड आई हैव अ सिस्ट? नो. सो व्हाट्स गोइंग टू बी देयर? Okay, so either she is going to come up with an acute cyst accident, for example, acute abdominal pain because of either torsion, or there can be a hemorrhage, or she might be, having severe pain, or the cyst might be ruptured. So वो आपके पास जो है वो acutely जो है वो present करेगी. ठीक है. So we have a just more suitable. We're going to have an acute presentation, or or it's going to be an incidental finding. Incidentally, when you are doing any other gynecological investigation, for example, you are doing a TVS in order to look for her endometrial thickness for CET, or to look for something else, and you find a cyst, or she is undergoing an investigation by another specialty. For example, the urology wants to see her bladder. Okay, and then in that scan for pelvic pathology we have a cyst. ठीक है. तो इंसिडेंटली या तो गायनेकोलॉजिकल इन्वेस्टिगेशन की में मिलेगी, गायनेकोलॉजिकल इमेजिंग, या किसी और स्पेशलिटी की इमेजिंग में आपको वो सिस्ट मिल जाएगी. अब आपने क्या करना है? आप नहीं करना है कि ओहो बड़ी सिस्ट है तो ऑपरेट कर दे. नहीं. You are going to do two things. There's just two things you have to keep in your mind. That one is TVS and the other is CA-125. These two things are the most important things. Okay. TVS can be complemented with a TES, लेकिन एब्डोमिनल प्रेफर्ड नहीं है. प्रेफर्ड है TVS. ठीक है. अगर आपको TVS में उसका साइज़ नहीं नज़र आ रहा है या बहुत एक्सटेंसिव है, फिर आप उसको कॉम्प्लीमेंट करेंगे विद एन एब्डोमिनल अल्ट्रासाउंड. ओके. एंड द सेकंड थिंग इज CA-125 लेवल. अच्छा, वेरी इंपॉर्टेंट थिंग दैट द स्टूडेंट्स डू नॉट नो इज़ कि CA-125 का रेज होना definitely indicates something dangerous, but if it's normal, it does not rule out malignancy. I'm going to repeat this line, that if CA-125 is raised, it's going to help you in your diagnostic pathway, but CA-125 being normal does not rule out malignancy. Okay, this is a very major mistake that kids make. They're like, CA-125 is 30, jao bibi ghar jao. Don't do this. Okay, you have to. Now, other than these two things, the third thing is your own assessment. Okay, these two things are very objective, right? CA-125 आपको lab वाले करके दे रहे हैं, scan आपको radiologist करके दे रहा है. Okay. Third thing is your history. You're gonna ask about her symptoms. If she is giving the abdominal pain, if she has you feel like she has ascites, or she has loss of appetite, a sudden loss of weight. So you're going to assess her, you're going to look at her BMI, you're going to assess her for an abdominal mass. On history, family history is very important. Family history of colon cancer, breast cancer, or ovarian cancer. If family history is positive, then with such a mass, the guideline says you have to refer her to a cancer center. Okay, and one very important thing, IBS. Okay, IBS is very common in young population. Every other person, like, oh my god, I have IBS. But if a woman more than 50 years of age comes to you with symptoms of IBS for over 1 year or 12 months, you are going to assess her for for malignancy. I'm not asking you to, do her all her markers, but in your mind, you should have, that I have to do a malignancy. For that, you're going to do a proper examination, order a scan. But what I'm saying that IBS in all women needs to be taken very seriously, okay? So I'm going to write serious with it, serious, okay? Okay? So I hope that, I know you're not understanding my writing, but let's just move forward with it. So now what really bothers the kids is the imaging pathway, okay? I'm asking you to do to do three things, okay? I'm asking you to do your own assessment, which includes your history and your examination. And then I'm asking you to do two definite things, which is the backbone of this guideline, that is TBS and CA 125, okay? But now the kids are like, what about CT scan? What about MRI? What about PET? No, the modality is that if in TBS with or without TAS, you find any features of malignancy, which I'm going to, tell you in the RMI score and IOTA scoring just in a minute. Any sus thing, TBS is sus, bro. Then you have to order a CT, abdomen, pelvis, okay? Very important. If the RMI is equal to or more than 200 after calculation, or you are visualizing something suspicious, features of a complex cyst, then do a CT scan. Okay, it's not second line. It's when you have these two things, suspicious features or RMI more than equal to 200. So these two are the indications for a CT scan, okay? Because you do it when you're suspecting a malignancy. And the another point in this guideline is when ultrasound is not helping. Let's say ultrasound is inconsequential. When, I don't know a scenario, please, if you know when is ultrasound inconsequential, then the second line is MRI. MRI is not, in the step-by-step imaging algorithm. It's second line when TBS is not giving you anything. When TBS is inconsequential, you're not going to go for a CT scan. You are going to go for a CT scan when there are two things. What are those? I just told you guys. When there are suspicious features and when the RMI score is equal to or more than 200. Otherwise, if TBS is not giving you anything, if it's not giving, then you have to go for an MRI because it's a second line imaging modality for this scenario. Okay? A very, very important point. So the three things that I just told you guys was, one is your own assessment, which includes history and examination. Other was TBS, and then you should know the whole imaging pathway, that when to go for a CT scan, when to pick up MRI. And then the third thing is CA 125. And I told you that CA 125 being normal does not rule out malignancy. Very important point, okay? So now the family history is a very important section in the guideline, which is a bit tricky, okay? So one is a family history of cancer, and the other two is the BRCA gene mutation. So first discuss the family history of cancer. So these women I'm just about to mention are at high risk of ovarian cancer and should be, assessed very carefully. And when you call a woman high risk based on the history, okay, if she has a first degree relative with, if she has one first degree relative with ovarian and breast cancer both, okay, or she has two relatives and both are having ovarian cancer and they both are first degree relatives of each other. This is 200, 1 OB, this one person has ovarian breast, both, or two people, both with ovarian, first two relatives of each other and first two relative of the female also. Of course, we're talking about the female over here. Second scenario, two people, one with ovarian, other with breast. The one with breast is diagnosed not under 50, okay? And the fourth one is three people, one with ovarian, the other two with breast, and the breast in this scenario is diagnosed under 60. I don't know what this means. I really don't know what is the reason that for a breast diagnosed under 50, she needs one with breast under 50 and the other with ovarian age not mentioned, and when breast cancer is diagnosed under 60, she needs two with this diagnosis and one with ovarian, so needs three relatives over here. ठीक है, ये हलवा बन रहा है. And then the other one is three with colon cancer, or she has two, among which one has colon cancer or the other one has any of the stomach, or we have ovarian or endometrial or urinary or small bowel cancer in 2 generations. And one of these cancers must be diagnosed under 50 and the affected relatives should be first relatives of each other. I know this is not making sense, but I can't explain it anymore, okay? So let's just again go through the family history. Based on which family history of cancer is she going to be high risk? When she has one relative with either both, or she has two and both of them has ovarian and are first relatives of each other, or she has one with ovarian, one with breast, and the breast is diagnosed under 50, or she has three relatives, one with ovarian, two with breast, and the breast is diagnosed under 60, or she has three with colon cancer, or she has two, one of them has colon cancer and the other one either has stomach, urinary, small bowel, or breast, not breast in this case, okay, breast is diagnosed separately, or a small bowel cancer, and one of these has to be diagnosed under 50, okay. Now the second point, अच्छा, तो हमने high risk women based on family history तो ले दिया. अब बेस्ड ऑन द बरका होता है 1 2, ठीक है, उसकी म्यूटेशन के बेसिस पे अब हम देखते हैं, ठीक है, कि क्या हमारे पास की सिग्निफिकेंस आती है, ठीक है. यहाँ पर मिसमैच रिपेयर जीन MMR. अब इसमें क्या है दैट ईदर शी इज़ अ नोन कैरियर. अगर हमें पता है कि उसमें बरका 1 2 या MMR है, तो हम प्रोटेक्टिव बायलेटरल सेल्फ इंजेक्टमी या सेल्फ इंजेक्टिव भी तो करते हैं ना, ठीक है, वो हम लेंस सिंड्रोम के साथ देखेंगे, बड़ी कॉमन चीज़ है ये. तो नॉन कैरियर है तो भाई मसला ही हल हो गया, हमें पता है. या फिर वो खुद अनटेस्टेड है लेकिन उसका फर्स्ट डिग्री रिलेटिव जो है उसको है म्यूटेशन, ठीक है. she is herself untested but her first degree relative has the known mutation, or she herself is untested and her second degree relative has that mutation, and both are connected by an unaffected man of an, okay, this is a very weird sentence, but both are connected by an unaffected man, okay. So this is based on the gene mutation. या तो खुद कैरियर हो, या तो उसकी फर्स्ट रिलेटिव नोन केस हो, या कैरियर के म्यूटेशन हो उसको, या फिर उसके सेकेंडरी रिलेटिव को हो, एंड बोथ ऑफ देम आर कनेक्टेड बाय एन अनअफेक्टेड मैन, ठीक है. So this is based on the the